much about data collection because our program is so unique in regards to what our providers have to do with all the data. It's almost like, we have a separate electronic medical records for our program because every single outcome for every single patient that we see needs to be sent to us. And that is why, we are so unique in the HCS. And there is, of course, kind of additional quality assurance that our patients are being seen in time. So, again, the way we kind of monitor our activities is not only through the claim, but also through submissions to detect. So the information how we collect our caseload and everything comes from two sources. One is from claims data, and another one from detect, where we have everything in regards to the final outcome for the patient. And that's how we're actually getting our funding from CDC. That's why data collection and how accurate it is so important, because CDC is looking at every single outcome, and if there is any kind of errors or a problem with the data submission, CDC will go after, believe or not, every single case. And, our case projections are different for state and for federal subset. And federal subset, I believe this year it's around 24,000 women. So we have to submit data for every single woman, to CDC. So you all know that, our data collection system called DETEC, and it's used to enter patient demographic data, obtain recipient ID number for billing, and enter the screening and diagnostic results. And if patient needs the treatment, not only we need to know the final diagnosis, but it is very important, we need to know the date when the treatment starts. As I already mentioned, we're using DETEC for monitoring the program caseload. We also, able to kind of querying report by multiple criteria such as NPI, CPT, and ICD-10 codes. It also helps us with quality assurance, program evaluation, and of course, very important, with case management payment, because only case management that requires immediate workup cycles are eligible for $50 of case management payment. So in regards to the data collections, our requirements are to maintain complete and accurate recipient data in DETEC. As you know, all the cycles supposed to be submitted within 30 days, regardless the results. And I think this is where we have some issues. So providers oftentimes enter the data later than 30 days. And unfortunately, that can be a problem, because, as you know, right now we're trying to make sure that our core indicators, which again, we will address, I believe, further, looks good. But if something is not entered within 30 days, we don't know that we have a new recipient that, whose results, have been already received. So it is very important when you train the providers to make sure that they understand that all the data have to be entered within 30 days. So other requirements is to submit complete data and the plan for each patient, and also correct data errors and input that is missing. And usually before the submission of the data to CDC, which we do twice a year, actually we're doing it as we speak. Our new submission data is April 15th, and it's also October 15th. So if there is any errors that generated by the tag, something was not entered accurately and some data does not correspond, with the other data entered for this patient, the tag, will flag it. And our colleagues in EDM, which is the data management unit, they would send the report to you with all these errors, if there is any. Sometimes there might be, none, but sometimes there can be a few, and you would need to contact the providers in a timely manner to make sure that those errors have been fixed. Also, signed, dated copies of the TAC online recipient data form must be filed in the patient medical records as the proof of the data entry. In case if the TAC is not available online, and we have this year one instance, there was a few hours when the TAC was not up, I believe due to some internet glitches. Providers also have ability to fill out the paper screening cycles data worksheets, and those sheets can be found in our EWC page with all the forms, but it's rarely need to be used because, as you know, you can enter the information 30 days retroactively. But in case you want to see how the tag fields look like, this is kind of a paper substitute with the instructions. Any questions?
No.
Okay. So let's talk about evidence-based intervention. Suzanne, do you mind, I really, like how you present that. Do you mind if I will, show the slides and you can talk about EBI?
Oh, sorry, I was on mute. Yes, of course.
Okay, wonderful. Thank you so much for that.
So as we know, the evidence-based interventions, we call them EBIs. So sometimes people get intimidated, but they're evidence-based interventions are practices or programs that are implemented at the clinics. Whoops. To increase screening rates. So it's really targeted towards the screening rate process. And the findings and recommendations are based on systematic reviews of the scientific literature, peer reviewed. So it's not just coming out of what people think, but what has actually been studied. And evidence across studies suggests multiple component interventions are most effective. And that's why we require that for the EBI project, for them to ask them for interventions and not just one. Okay. And this is a really great little reminder, and you might want to just have it around somewhere else. It's a nice little grid. It just says what are the strategies they're recommending for breast and cervical. Right now, what we're doing is just breast and colorectal, but if the clinic is interested in increasing the cervical, then you can come back here and you can see like, oh, group education, you think that's great for everybody, but actually hasn't showed to influence cervical rates that significantly. So if somebody talks about that, you might want them to do something else as like one-on-one education instead. So this is a really handy little grid. And basically the areas are increasing client demand, increasing client access, and increasing provider delivery. It looks like to people that EWC is itself is it reducing out-of-pocket costs. So we're already doing something in these clinics by enrolling the providers. You're already getting them towards a better screening rate because they have more access, client access. Okay, next slide. So we like to encourage the clinics to utilize evidence-based interventions to increase screening rates. We do have a separate project where select clinics get grants, and so that's what you participate in at the bi-monthly meetings. And however, as I said, when you're talking to providers during this orientation, you can tell them that we encourage them to utilize some of the resources we have for from the CDC if they're interested in expanding their. This is a nice little one. All right. Any questions about EBIs? I know you hear that a lot. The other thing I would add is that we're going to be a little bit more, we're getting our systems better for this current way we're going about things, and so with the grant base. And so in the next cycle, which starts in September, the grant goes out in September, we're going to really have you be able to access their implementation plans for the clinics that are in your area so that you can support them there. So we haven't honed down that process. So don't worry if you're wondering, oh, do I have an EBI? The important thing is that you have an EBI tracking form. If you don't, please email me and I'll send it to you. And then when you participate in the bi-monthly meetings, you put that information. Any questions about the EBIs?
Okay, well, thank you so much, Suzanne, for presenting evidence-based. I also would like to add that, hopefully, I don't know if you heard what we've discussed during the last meeting with clinical coordinators, but we are really looking forward to start receiving provider activity report, which shows different categories that of the provider activity, such as enrollments, number of the claims, number of normal, abnormal cycles, and complete cycles, and of course also CPPIs. So we called it provider activity report, but in a nutshell, it's really one of the evidence-based intervention called provider assessment and feedback. And, this is one of the strategies that show to be, very important and really working. So providers can see how they perform, compare with the other providers. So hopefully in the future, we will be implementing one of the EBIs for all the providers. So with that, let me go to clinical evaluation and support. So clinical evaluation is very important because we really would like to know how our program functions, how well providers perform, and how well we perform as the program. And, what helps us with that, it's the, data that comes from the DTAC. I just mentioned provider activity report, and that's actually the report that, will help us to evaluate the activities. And part of this report is core program performance indicators, which we briefly, abbreviates as a CPPIs. Those core program performance indicators come as the performance measure from CDC or NBC CDP. Another evaluation that is very important that we're going to sort of re-implement because that activity was on hold during the COVID and post-COVID time, it's the provider site reviews. And again, hopefully we will base whether or not provider need the site reviews based on DTAC data, provider activity report, and CPPI. And if we see a lot of deficiencies, in a certain, provider, then we may decide that this provider needs to have a, site review and more training and more support. Also, we've already talked about DTAC error remediation reports that comes before the data submission in April and October. Incidents report, it's when you kind of come across of some sort of an issue. It may be a patient complaint. It may be just not necessarily a complaint, but a patient call. Or it may be something that provider raised to you as as a problem in their clinic and ask for your help. So also client feedback. Your clients, can provide you feedback, directly, or they can email it, to us. And we also do collect, success stories, which is also client feedback. And those stories are also submitted to CDC. And of course, whatever you observe, during your everyday interaction with the provider, would also be, part of the clinical evaluation, for us. So let's talk a little bit about CPPI. As I said, they are established by NBC-CDP. They are adapted from the clinical data, and they are submitted to CDC for program monitoring. They abstracted from, all the, detect data, and unfortunately, during the last rounds of the submission, we've been alerted that some of the CPPI were not met. So we're able to see kind of through the last months, what is happening, with CPPI and how they may change. So they are never the same. So every single day as the providers enter some data, those CPPI can turn into worse or can turn into better. And in a moment we will be talking about CPPI, so you will understand why is that. And as I mentioned before, very important why we need to meet those criteria, because our federal funding depends on that. So this is how the CPPI looks like. So we have 5 cervical and 4 breast criteria, and I'm going to go over them so you understand them. Do you remember seeing, them before during the our meeting with the clinical coordinators? Do they look familiar?
Yes, it does.
Yeah.
Okay. Ec- Excellent. So the first one is kind of a very unique indicator because it doesn't really reflect on the activities of the provider, but more of our recruitment efforts, in regards to the work of health educators. So it's the percentage of women age 30 and older who receive their first cancer screening through the program and who have never been screened or not been screened in the last 10 years. So we really try to make sure that all the women do have access to cervical cancer screening, and we're really trying to get to those women who are rarely or never screened. And rarely means that they did not have, screening in the last 10 years. And CDC standards is pretty high, it's 35%. And it's very difficult to meet this indicator because I think as the time goes by, and screening is available, throughout California, it's very difficult to meet this standard. So I don't think we have been consistently meeting this standard over the years. But CDC is well aware that this is a challenging one. And again, I don't know if CDC will ever put this, I mean, kind of turn this percentage down, or will keep it at 35. But unfortunately, we're still not able to meet this indicator. And again, I have doubts that we really can, find the women who have not been screened. I think it's pretty difficult. So the other, diagnostic measures, they're more clinical. So it's the percentage of cervical cancer screening records with planned and complete diagnostic follow-up. So the percentage of those screening records should be more than 90%. Next one is the percentage of cervical cancer screening records with planned and complete diagnostic follow-up, and time between screening and final diagnosis should be less than 60 days. So this is the, timeliness indicator. And the percentage of the standard should be that the more than 75% of our records should be, I mean, the percentage of our records that were closed within 60 days should be more than 75, percent. And the time, between screening to the final diagnosis means that the women had, an abnormal screening results, and we were able to get to the final diagnosis within 60 days. Next one. So percentage of cervical cancer records with the final diagnosis of high-grade lesion, CIN1, CIN3, or carcinoma in situ or invasive cancer have treatment started. 90 days. So pretty much that, everybody who has the final diagnosis of the cancer, 90% of these people, starts the treatment. Um, Next one, again, the timeliness. So percentage of cervical cancer records with the final diagnosis of high-grade lesion, CIN1, CIN3, CIS, or invasive cancer, with the time between the final diagnosis to treatment less than 60 days. So that means that everyone with the cancer should start the treatment immediately, but no longer than 60 days after the final diagnosis. And percentage of this record should be more than 18. Any questions here for the cervical cancer? So the issue that we're currently having is the percentage of it's indicator number 3. So it appears that we are not able to meet the 60 days between abnormal cervical cancer screening and the final diagnosis. And oftentimes the reason is availability of a colposcopy. So please let us know if this is the problem in your region. We're trying to investigate because this is a new thing to us. We used to meet this indicator before. So we're trying to figure out whether or not there is any other colposcopy facilities where a patient can be referred. Again, so if that is the problem in your region, please let us know. But also, one of your responsibilities would be looking for other medical facilities to make sure that we meet, 60 days of the final diagnosis. And also, when you train providers, whether it's a new provider or existing provider, it's extremely important for the providers to understand our CPPIs. It's actually, I would say, should be the focus of your training that, our program is really about completedness, comprehensiveness, and also timeliness of the screening. So it should not be a surprise. And, providers should understand our CPPIs, really well and be able, to meet them. But again, if you're working with the providers, make sure that they have available colposcopy and that the time of the wait, should be less than 60 days. And if it's problematic, whether or not there can be other facilities that provide colposcopy who can, help with, with this issue. If there is no questions, let's talk about breast. They're very similar, they're almost identical, but let's go over them. So percentage of breast cancer screening records with abnormal results and completed diagnostic follow-up. We expect that 90% of our patients should have this completed records. Percentage of breast cancer screening records with completed follow-up and time between abnormal screening and final diagnosis should also be no more than 60 days. And percentage of these records should be equal or greater than 75%. Percentage of breast records with the final diagnosis of carcinoma in situ, DCIS, or invasive breast cancer that have the treatment started should be more than 90%. So 90% of the patient that basically was identified, with the condition that requires treatment should be more than 90%. And now the final criteria also about timeliness, that the percentage of breast cancer records with the final diagnosis of CIS, DCIS, or invasive cancer and time between the final diagnosis and treatment should be less than 60 days, and percentage of this record should be equal or greater than 18. Any questions about CPPIs? Okay. moving along. So right now we in the process of revision of our site review tools because we haven't done the site review, as I said, since COVID. Um, so how do we do the site review? So site review should be based on CPPI and provider activity report and occurrence report. Uh, Site reviews are performed by clinical coordinators and include staff interview, observation, and review of the medical records. Um, so for the review of the medical records, we usually ask for breast and cervical screening medical records of actual EWC recipients. We also have evaluation scores. So people who, no, excuse me, not people, clinic that meet, our requirements in 100 to 90% means that they meet the requirements, with the flying colors. 89 to 80, that means that provider needs some improvement, some follow-up, but that's minimal. 79 to 70 means that they fail the site review and the action plan is required. And if the provider score is less than 70%, it means that it definitely, fails the site visit. Again, action plan is required, but we may also, consider the disenrollment. But I think everything depends on what, kind of finding, are there. And those findings needs to be discussed with the nurse consultant. And each cases, should be, looked at separately. So part of the clinical site review is really about how the program, our program, EWC, have been administered in the clinic. Does the clinic have an effective infrastructure to implement EWC program? And there should be an evidence, what clinic has, whether or not they have the effective referral provider network, adequate enrollment procedure, complete and accurate data entry into the tag, and system in place to ensure timely patient tracking and case management. I think we've talked about that really a lot, but that's really what our program is about, to make sure that everyone gets the final diagnosis and treatment. Notification of the results, recall for routine visits, diagnostic procedures, and necessary follow-up, referral for diagnostic procedures and treatment, and enrollment in BCCTP if necessary, and also a list of resources that are non-covered by EWC services. So for the enrollment, we need to make sure that all the enrollment forms are completed, signed, and present in the medical records. That all this data, produced and signed, as a detect data entry form. And all patients' contact recorded, including phone calls, and all the test results are present in the medical records. We also require that the printed recipient information form is in the medical records. And the clinic has to provide evidence of accurate and complete data entry for each cycle. And in the documentation in the medical records, we have the notification of the results and referral for diagnostic and treatment within the timeliness and documented in the records. Final copy of recipient ID card is in the medical records, and if we notifying patients about anything abnormal, there should be at least 3 attempts to notify regarding abnormal test results, and the final should be certified mail. And we'll talk about it, on quite a few slides before. So besides administrative portion for the site visit, we also have breast and cervical portion. So we want to make sure that if CB was done, it is, well documented, that mammography findings is in the file, that all the abnormal CB received follow-up, um, all the abnormal mammograms also received appropriate follow-up, and findings from CBE if it was performed, and mammogram and the biopsy are correlated. So what it means is that if something is found on CBE, whether or not it correlates with the findings on the mammogram and the biopsy. So the three together, should kind of, come along together. And if mammogram does not find anything or the biopsy doesn't find, but CBE still has, a lesion or a finding, that needs, additional follow-up, or make sure that that the provider and the referral provider agree with each other's, findings, and there is no more concern that the cancer could have been missed. In regards to this cervical cancer, PAP and co-test, whether it's PAP or HPV, and the primary HPV screening results are documented. Appropriate follow-up of abnormal results, is being prescribed, and all the appropriate screening intervals are followed. In regards to error remediation, medical records are consolidated in DTAC, and oftentimes there might be some sort of an omission or data entry error or incorrect interpretation of the medical records, and that all may result, what I told you before, in flagging certain records as the error, and that needs to be corrected. And you oftentimes will be the one who will contact primary care provider and make sure those records have been, corrected and consolidated. Incidents report, it's kind of, by default, you know what to do. It's either technical assistance by you or by EWC staff. It may sometimes, lead to the site review and corrective action plan. So, if provider have, any kind of, concerns and they would like to bring it, to us, they can, send it directly to you, or they can send it to this email, and that's our kind of, general mailbox for our program. Any questions? No? We have completed our our review of all the slides. There have been, 148, so it's a lot, but hopefully that was helpful, to you. So I'm giving you a moment just, to breathe out. And again, raise your hand if you have any questions. Okay. I hear none at this moment. Um, So I would like to go and start our cervical cancer review. This is a clinical portion. So let me start with USPSTF recommendation. So today we will be talking about cervical cancer screening results. Again, not diagnostic, only screenings, and we're going to go over screening recommendations. Um, who who has reviewed this recommendation from United States Preventative Task Force before? Anyone? Okay, let's talk a little bit, why we're utilizing USPSTF recommendations. So this recommendation is done by the group of the experts from very, different specialties. And those experts are usually selected by United States government, and, the composition of this group uh, is actually varied because they are selected every 5 years. Again, it's usually top specialists, and their role is to review all the evidence, all the available research on very different topics, not just cancer, not just screening, and to come up with the different recommendations. So they kind of like and arbitrary, judges of the, latest and newest, research. But they look at the entire body of the research, whether or not, it's very recent or it's the research that, have been done, a while ago and come up with this recommendation. Sometimes this recommendation may cause, some discussions among the specialists, but with the cervical cancer screening, I think everyone was kind of, in alliance with what USPSTF has provided us. The latest update was in the August of 2018. As you can see, here is this, kind of a, yellow flag, is that this topic is being updated. And actually, it's been updated for quite a while. We're a little bit surprised that we don't have the recommendation just yet because the public period, I think, was more than a year and a half ago, but we still don't have the update. So don't be surprised if it changes anytime because, it may. And now let's look at the summary of this recommendation. But before we go into the recommendation, let's understand what this grade means. You see this grade A and D. I'm going to click on word grade and you will see what it means. But I'm going to say that all the recommendation A and B are supposed to be covered by all the insurances in the United States. And you will see why. And then the recommendation below grade B, it's a subject for the insurance to decide whether or not it will be covered. So it is really important to understand those recommendations. And grade A shows that there is a high certainty that the net benefit of a certain recommendation is substantial. So pretty much grade A means absolutely, definitely, a recommended either intervention or recommendation, or in our case, screening recommendation. So grade B, USPSTF recommends the service. There's a high certainty that the net benefit is moderate, or there is a moderate certainty that the net benefit is moderate or substantial. So basically, there is much more pros than cons to recommend something. There is more evidence that there is more benefit rather than risk. Then the recommendation C shows that USPSTF recommends selectively offering or providing the services to individual based on professional judgment and patient preference. There is at least moderate certainty that the net benefit is small. So as you can see, there is, kind of more uncertainty whether or not, something needs to be recommended. And recommendation C pretty much just tells that it will be up to the provider and the patient to utilize certain recommendation, and there might be a benefit. There is less risk, more benefit, but there is not enough certainty to recommend it to everybody. Then the recommendation D means USPSTF recommends against the services, and there is a moderate or high certainty that the service has no net benefit and that the harms outweigh the benefit. And pretty much the recommendation is to discourage the use of this service. And the final is I. I means insufficient. So USPSTF concludes that the current evidence insufficient to assess the balance of benefits and harms of the service. Evidence is lacking or poor quality or conflicting, and the balance of the benefits and harms cannot be determined. So in a nutshell, I means that at this moment there is just not enough evidence. It's not that the recommendation is encouraged or discouraged, but there's really we cannot really comment on something that does not have enough body of the research to move forward with certain recommendations. Any questions here? No. Okay. So, so the recommendation for the screening are, very straightforward. Women aged 21 to 61 are recommended the following screening recommendation. Women should be screened with the 3-year cytology alone for women aged 21 to 29. Um, so cervical cytology, it's pretty much a pap test. And I want to make sure that you understand the word histology and cytology. Do you know the difference between cytology or histology? Anyone?
No, I don't. Can we go over that?
Of course. So you may see cytology all the time, and I want to be sure that you're comfortable with this term. So cytology, cyto means cell. So cytology is when you take a sample that at the end will bring you the sample of the cells of a certain organ. So cytology can be not only with the cervical cancer. It can be cytology can be with any body of the organ. But it means that the sample that we take can only provide us with a few cells in this organ. So when you take a pap test and when you take a brush and do the cytology, you pretty much just able to see a few cells, and you can determine, and the sample of the cells should be sufficient, because sometimes we have insufficient cytology, meaning just too few cells. That is not enough to make a to really read the pap test, and to determine whether this pap is normal or abnormal. So cytology means cells. And when we talk about histology, um, it's really more when we're looking at the abnormal pap test or abnormal HPV, and we need, further management. Then we go and we take a biopsy. And when you take a biopsy, you do a histological exam, which means tissue. So histology means that we having not already cells, but we having, piece of a tissue that can be cut in slice and can be examined as the not just the cells but as the tissue. Do you see the difference?
Yes. Thank you.
Okay, so don't be thrown away by the word of the cytology, because cytology means pap test. So it's for you it should be kind of interchangeable term. Pap test, cytology, it's the same thing. Um, so actually cytology can be done until age of 65. So every 3 years, women should be checked. And when we do the cytology, we're looking for abnormal cells, because pap test identify whether or not there is something abnormal in the cells. Um, but do you know why we're doing the HPV testing after age 30? Anyone? Why we're looking for the HPV? Maybe I should rephrase the question. Why are we screening for HPV?
To see if the cells have been affected by the HPV virus.
Yes, actually, cervical cancer is a very unique cancer because, in 99.9%, cervical cancer is caused by HPV. And that's really unique compared with the other cancers. Other cancers might have, other risk factors or reasons for the cells to grow out of the proportion, and and show cancerous property. But for cervical cancer is really the virus, and the virus that is harbored at a specific place, which, as I told you before, is usually harbored in the transformational zone, when the inner epithelium, which is columnar epithelium, inside the cervix, meets the squamous epithelium, outside the cervix. And when this epithelium is merging, one epithelium transform into the other. So columnar epithelium transform into the squamous, and that's why we call it transformational zone. And that's where the virus, love to harbor, and it can persist there for a very, very long period of time. Um, and what is important to remember is that, the virus, can be harbored there for a very long, period of time, but um, it doesn't really, change the cells. But the persistent infection, usually more than a year, sometimes more than 2 years, can lead to the change, in the um, in the cells. And the virus can actually start to causing the changes that later we can read as CIN 2 and CIN 3, and it can lead, to the cancer. And usually it takes forever for this cancer to grow, but that's one of the major reasons why we're looking for HPV, because it's really the cause of the cancer. That's why, right now, primary HPV testing or co-testing is actually has the leading role in regards to the screening for cervical cancer. And there is also the reason why we screening women at age 30 rather than at age 20, because HPV is the most common sexually transmitted um, infection. We don't want to call it disease because it's not really a disease, it's just an infection. And almost every single adult patient who was engaged in some sort of sexual activity, carries that at some point in life. And this virus is very, transient, so it comes and goes. It's almost like, any upper respiratory infection. So you infected at one time, and you recover from that. So our immunity, our body is able to clean this virus very easily without, any kind of problems. But unfortunately, some women may harbor it for a longer period of time, and the older the women, the more likelihood that this virus can be harbored. So younger women more often affected, but they also clean this virus, very easily. And that's the reason why we're not really screening younger population, because we may find the virus all the time, and it doesn't mean that we immediately have to jump and do something. But with the kind of, I would say, older population, the presence of the virus can mean that, this infection can be more persistent, and we need to do appropriate follow-ups and decide what to do if we identify the virus in women age 30 to 65. So what you need to remember that we screen for cervical cancer, every 3 years, and it can be done until age of 65. Nevertheless, at age 30, we have much more, I would say, appropriate and more sensitive screening, which would be the HPV. And you can do HPV alone, or you can do HPV with cytology. So if you do it alone and HPV is abnormal, what is usually done is the reflex cytology. So if HPV is abnormal, on the same sample, you can look actually at the pap test. You can look at the cells, or you can look at the cytology and see if those cells have changed or not. And that can really, influence your, further, management. Any questions here?
No.
Okay, so we do not recommend screening for women younger than 25, the 21. Yes, in theory, and also, based on the, medical literature, there were reported just a few cases of the cervical cancer in women younger than 21. But there is no point of screening younger women than 21, because we almost never find a cancer in the younger population, and there is no point of subjecting so many women, to this procedure, because any intervention can lead to potential, further management and biopsies, and it's unnecessary in the younger population. And it doesn't really matter when the woman, starts her, sexual activity, or how many partners she has. At this moment, we don't screen women younger than 21. If a woman has any kind of symptoms that concerning for cervical cancer. Of course, she needs to be examined and evaluated with the pap test before age of 21. But if she's asymptomatic, we're starting screening only at age 21. That's why, this recommendation, for women younger than 21D, it means that we recommend against this. So we had a very long conversation regarding women who had a hysterectomy. Um, and if you remember, the women who had a hysterectomy and the cervix was removed, and the reason for the removal of the uterus was a history other than a cervical cancer screening. The screening for this cervical cancer should be stopped. So in other words, if the uterus was removed for any reason other than cervical cancer, we no longer screen this woman. But do you remember what we've talked about when we don't know what was the reason for removal of the uterus? If we don't have a documented history, if records are not available and we don't know why um, the uterus with the cervix was removed, we always assume the worst. We assume that the uterus could have been removed because of the cervical cancer, cervical precancer, CIN 2 or CIN 3. And in those cases, we would continue to screen this woman. And of course, we're mostly talking about immigrant women, whose records are not accessible to a provider. And last thing that, I think we've talked a lot already is that we no longer screening women after age of 65, but under a very important condition. If her previous screening was adequate, and adequate screening means that the woman had at least either 3 negative pap tests in the last 10 years, or she had 2 negative primary HPV or co-testing in the last 5 years. If women did not have that, history of, normal exams, we will continue to screen her until we meet this, 10 years benchmark. Or if the woman had precancerous lesion in the past, she would continue to have a screening, I would say indefinitely, probably until maybe her other comorbidities will start to play a role in continuous screening. But we continue to screen women with precancerous condition, after age of 65. Any questions here? So these recommendations are pretty straightforward. So just to remember, 3 years or 5 year interval in the beginning of initiation of the screening at age 21, and usually finishing at age 65, with the benchmark of age 30 where HPV becomes available. So at the next, meeting, I'm also going to show you a little bit more in-depth presentation regarding, the history of the HPV viruses, and we will go over some additional slides. But today we're just addressing the recommendations from USPSTF. But I also want to talk about American Cancer Society. American Cancer Society is also one of the most reputable group that release a lot of recommendations in regards to the cancer screening. Um, but we don't follow these recommendations. And these recommendations for cervical cancer have been updated a few years ago, but they are different from USPSTF. And the reason why I want to bring it up, because, some providers and also some women may want to follow this recommendation, and we have to be very clear in regards to what we cover or not. So based on the recent evidence, American Cancer Society recommends start screening at age 25. And starting at age 25, they actually do recommend to start with the primary HPV test every 5 years. And they recommend HPV testing over the pap, test. If USPSTF kind of silent on that, although everyone, in the community, medical community agrees that HPV is much more sensitive, USPSTF does not really make this determination, and ACS actually does say the HPV is more superior than pap test. And it says that if primary HPV testing is not available, screening may be done with either co-testing that combines HPV with pap test or a pap test alone. Um, Fortunately, primary HPV testing is available, throughout the nation, without any problems. But again, this is the recommendation, and you can see the difference. It's different that the initiation is at age 25, and that at age 25 they start, primary HPV. So it's almost like a compromise between age 21 and 30. And they try to kind of unify the recommendation so there is no difference between ages and between what screening methodology to choose. Um, we don't cover HPV at age 25, so it is really important because if the providers do choose this method, our program will not cover that. Any questions here? Okay. Was this topic, kind of, difficult to follow, to understand, or was it easy in regards to the, difference in recommendations and why ACS is different from USPSTF?
Yeah, it's easy to follow.
Thank you, Brianda. Okay. So I will conclude our meeting today in regards to cervical recommendation. I think we have a session tomorrow, right?
Yes.
Okay, so we will continue to talk about cervical cancer screening, and it will be more, it will be, a different, presentation. But I'm going to show you the slides of my colleague. He did this presentation, during the last meeting with clinical coordinators at our regional meeting in August. So we will go over the natural history of cervical cancer and talk about it, and then we will continue with the breast cancer recommendation. How is that?
Sounds good. Thank
Sounds
you.
great.
Okay.
Thank you.